Next question for the evening is, hi, Dr. Mike. Thanks for all you do. Seriously, let me take a moment. Thanks for all you do. Y'all support my content. Listen, I really have no reason to gripe. Even my trolls don't bother me anymore like they did. I'm amazed at how liberating the block button is when you're just going to be a troll. There's a difference between disagreeing and trolling. I can handle disagreement all day long, but some people are just mean. And I don't have a community that's full of just mean people, and I just want you to know that I appreciate all that you do. Thank you. Okay? Question. What do you think about pain patches? I'd like to ask my doctor about it, because with the oral pain meds, there is such a high, and then a lull, and then you have to take the next dose, then feel good again. It's a vicious cycle. I'd like to keep at a steady pace. Let me go over that in a couple different ways. First of all, there are very few pain patches, okay? There's the buprenorphine patch that's Butrans, and there is obviously fentanyl patches, which have kind of fallen out of favor because of illicit fentanyl. But they are they're actually a very useful treatment modality. But I don't use them very much, and let me explain why. Fentanyl patches can be chewed to overdose, okay? That was a big thing before illicit fentanyl was a thing, is that addicts would get a hold of people's fentanyl patches and they would eat them, and some of them would die. So I think you might be a good candidate based on the soundness of your question, but I just need you to understand why some people are reticent to use fentanyl. And I don't like buprenorphine patches as part of an overall plan. If I have someone on a buprenorphine patch, normally they're not on pain medicine in addition. They're only on the buprenorphine patch, and a limited number of people can be maintained on Butrans only, okay? The dosing at the highest dose is not really that great, okay? So I'm not saying it's not helpful for anybody, because there are definite people that it really is. But the problem is when you try to add opioids to it, the buprenorphine competes too much for the receptor sites, and you don't really get the benefit of the short-acting that you're hoping to get. Okay, the short-acting really tends the benefit of the short-acting is really muted, and so I don't really like that with buprenorphine, and I don't like a lot of additive medicines to fentanyl patches, because again, fentanyl high efficacy, and it's really going to get a significant additive effect for respiratory depression. You really have to be careful with those things. And because of that, very few people write fentanyl patches. Let me tell you the people I normally write for fentanyl patches. It's normally low dose people who are in chronic pain and yet have a hard time verbalizing that pain. Okay? They're normally fairly incapacitated. They cannot usually apply the patch themselves. You see what I'm saying? And it's something that you can watch their non-specific, their non-verbal to kind of judge the effectiveness. You can really watch the respiratory effort, and you can control a lot, okay? People with free will like you and me, it's just, I use them, but I don't use them very often, okay? It's the right patient. And for me, it's approximately 4 right patients per year out of all the patients that I treat. You see what I'm saying? It's just that. So here's my better advice for you. I would rather you talk about being on a Q12-hour medicine like a Xtampza or maybe a Nucynta extended release, or a MS Contin, an OxyContin, something where you take the dose at 6 and 6, or 7 and 7, and 8 and 8, 9 and 9, whatever, okay? And then you have short-acting in the middle of it, okay? I think it's going to meet your need for that more consistent, getting rid of the peaks and the valleys. Because normally when you are using an extended release form of medicine, you put at least 50% of your total morphine equivalents for the day into the extended release, and put more like, 30, 40, 50% in the short acting that is your breakthrough. That's the term that we use. But in reality, what I think it's not even that's not a very good term, because even long acting isn't designed to take all your pain away. I would call the short acting medicines my activity meds. Okay, these are my baseline meds, and these are my activity meds. Anyway, I hope that's helpful. It's a great idea. I'm not telling you don't ask, because you really might be a great candidate for it. You just might be one of those 4 people per year, okay? I'm just explaining to you why it's an uphill battle, and I would not be part of a plan that combined buprenorphine patches with oral opioids just because I haven't had great outcomes. I don't find the plan actually works all that well. I had one person that it really worked well on, but even she's not doing that anymore, okay? Love you, no buts.